everybody. Is that cool?
Sorry, I apologize. I was working with Brendan with the live stream quick. So I'll get you folks all unmuted.
Perfect. Thank you, Tish. All right. Let me mess with my view here so I can see everybody. What do we have? One, two, three, four. Peter's here. At least the top of his cabinets are here. And Philip, are you here?
Yes.
Is Philip here?
I'm here.
Okay.
Eric Hart's here, Elizabeth.
Yeah, I see you, Eric.
I
Philip was the only one I
I
didn't have
couldn't
accounted
speak
to,
till
so I
just a
see you now,
moment
Philip.
ago.
Well, hi everybody. Remember these meetings? It's like a blast from the past. All right, so I would like to call this meeting of the Monona Grove School District Board of Education to order at 6:35 p.m. Has there been a declaration of public notice?
Sorry, yes, there has been.
Thank you, Tish. Before we get started today, I want to thank everyone for joining us. As a reminder, for board members, it's been a while since we've done a Zoom meeting, but we'll be moderating the discussion with the raise hand feature. So if you go down to the bottom of your screen, you should see a button that says react, and there should be a raised hand. If you have something that you want to say, please do that. And I'll call on folks in the order with which they are received. You should be able to mute and unmute yourselves now. For those of you who are joining us live via Zoom, thank you very much. You'll be here to listen. So please keep yourselves on mute. Will also be recorded and posted as well. So folks that aren't able to join us today will be able to see and hear the conversation. So our main topic for today, sorry, I'm only on one screen because my other screen is to continue our discussion around insurance. So I wanted, Dr. Frederick, I didn't know if you and Kristen wanted to kick us off a little bit, and then we'll kind of get into a discussion.
Yeah, happy to do so. I'm also running multiple screens here and a little out of practice, so might be a little clunky, but thank you for giving me the opportunity. Just wanted to reground everybody in where we've been, how we ended up here, and really what the question around discussion is for tonight. So the district has last year offered two plans. You could pick a dean provider or the GHC provider. And inside of those, the deductibles and copays were all very similar. The district, from a perspective of employee, pays 90% of the lowest cost plan. So for last year, that was GHC. And we currently have 216 employees that are employed by our using Dean and 237 that are using GHC. For some people, geography dictates that plan. GHC is pretty limited to the Dane County area, whereas Dean has a wider network. So every fall, we get our renewal notices to see what our renewals will be. And as a reminder to everybody, it's a little weird. Insurance works on the calendar year. So insurance is January to December 30th. So we're in the middle of a contract year. Insurance comes due for January. So on September 17th, status quo would be. And you can see here, there was about a 5% increase for GHC and pretty substantial increase for Dean, 42% for singles and 52% for families. As we looked at this, we're also in the middle of a relatively large budget crisis. Remind people, a month ago, we went forward looking for a 7 million loan to be a stopgap because we had such a substantial cash flow problem that if we didn't get that loan, we wouldn't have been able to pay our bills on October 4th. And when I say bills, I don't even just mean our vendors, I mean being able to pay our employees. So obviously in all of that, constantly thinking about how we are going to move forward in a way that is fiscally sustainable. So one of the things that I asked Kristen to do is to look into what were some ideas around sustainability for healthcare. Healthcare is 12.2% of our operating budget. In Monona Grove, most districts is about 10. So we run high, and really looking at, is there a different way to think about this with a couple sustainability strategies in mind? Competitive health benefits as we think to attract and retain staff, and an emphasis on health and well-being. Also thinking about how do we move from a sick care model to wellness, and thinking about access with a wellness clinic. Again, improving our access in their labs while providing staff with the ability to make some decisions about how they use their money, and also mitigate impact of health insurance on district finances, as well as a path towards self-funding that would include some freedom of choice through direct contracting, flexible plan design, and network changes. Instead of every year asking the insurance company, like, what's our renewal rate going to be? This gives us the opportunity for us to dictate those things and have some more we asked both of our healthcare providers that we're currently working with, GHC and Dean, to think about how they could help us towards those goals. So more of a direct clinic model. How do we use that money to put the money into our employees' hands instead of the insurance company through the HSA? Also think about what is working for other systems in the area and working towards freedom of choice. GHC was not aligned with offering an HSA. They feel that their premiums at the 5% increase, and the model that they have is providing adequate access and cost. So they did not give us a offering. Dean came back with a really aggressive model. They came back with a proposed HSA that would reduce overall premiums for staff in the district by 2.5 million. That would be a substantial funds to go towards the staff in form of HSA deposits. Also lower costs for payroll deductions out of employees' payroll, a unit clinic that would be new just to us, out-of-pocket expenses decreasing, improved reporting. All of our employees using one carrier would give us an opportunity to look at what are all the meds, what are the appointments, really get an understanding of what is the overall health of our population and how could we do some wellness initiatives to move forward. Also would be a 2-year bridge to having the ability to be self-insured, and also address some of our issues with funding by not having increased healthcare costs year to year. So they came back, and with moving to a single carrier with a high deductible plan at $3,000 for singles and $6,000 for family. And I'd remind you that that means total out of pocket would not exceed that. District would contribute $2,500 for a single and $5,000 for a family to offset that $3,000 and $6,000, and also develop a wellness clinic in partnership with Dean that would be dedicated to our population only. In doing so, we were given a design that offers this to employees. And I think it's important for us to look at that for a minute, because I want people to really understand that there's still choice. It is a Dean insurance provided option, but there's still choice. There is the Dean high deductible HMO. There's the Dean high deductible POS or PPO. There also is the traditional model of the 200 and 400 HMO and PPO. Now you can see the differences on the bottom line there, where what would the out-of-pocket premiums be. The premiums do go up with the premier kind of package being the high deductible HMO, and then differences that go from there. But there are still options. Those were not eliminated for people who want freedom to go out of network. So as we look at those proposed plans, what does that mean for people's pocketbook? And I think that's important us to think about. If people were to make the switch into the plan, if people have GHC now, the plan renewal for 2025, staying where they're at would be this second column. If we moved everybody to Dean, it would be the third column. And you can see the decrease. And the percentage of decrease that would happen. Obviously, the people that would benefit the most from a savings perspective would be the people that are currently with Dean. Just want to call that out right there, but there is a savings out of pocket for people with GHC also. what that deductible and out of pocket looks like compared to the current. Want to really help people understand how that HSA contribution offsets the rate that is currently in that deductible. So if you take a single person and it's now the $200 deductible and the proposed would be $3,000, but we're funding $2,500 of it, that proposed net deductible is $500 if you subtract the $200 to $300. So the difference would be $300 for single and $600 for families. And then also looking at this max out of pocket. In our current plan, you go up to $6,600 for a single and $13,200 for a family. This would be moving to $3,000, $6,000. So you can see there's quite a bit of savings for our families that have high medical costs. They would meet their deductible much faster. Status quo benefit plan, do want to continue to let people know that that is the other option that we're looking at. If we make no changes and stay with this, the people that are with Dean will see a substantial increase. They'll go up to a family would be $312 a month out of their paycheck, or $148 for employees. Obviously, the 5% that would go to GHC doesn't have as much as an impact. Because that is the lower cost that the district pays. So I'm going to stop there because I want to just move forward with thinking of, those were really the bigger picture. I think reminding everybody the why of thinking about it's twofold. One, how do we make sure that we have a good, robust offering for employees? And also, how do we also make sure that we're in this plan? Obviously, as a new superintendent, it would have been my first move out of the gate to bring things timely forward to the board for consideration as we move into a space of some budget difficulties that are going to be things like we hadn't seen in recent years. So wanted to lay that foundation. I know there's lots of questions and things that the board had that we wanted to have the opportunity. Kristen is on this call as well as myself, and then several people from Dean.
Great, thank you, Tanya. I know, Al, you're on the call, and I know that there's some representatives from Dean here too. We had a lot of coverage questions at our meeting on Wednesday. So why don't we do a quick introduction of the Dean folks, and then we can open it up to the board for questions around coverage directed to Dean, or questions about plan design for the administration.
Sure. Thank you. So last board meeting, we had multiple people from Dean, specifically from SSM leadership, Dr. Mike Weber, and from the clinic management, Sandy Cowan, and clinic project manager. In addition to them, they've each brought a couple of individuals to support them to make, I'd say in any questions that they don't specifically have answers, it would help them to support in their answers. So I don't know if we want to start with just those three in terms of the introduction, and then from there they can expand.
Yeah, that sounds great.
So Dr. Ottenbaker, I don't know if you want to kick things off from the SSM standpoint.
Yeah, Dave Ottenbaker, I'm a family medicine physician by background. I currently serve as one of the VPs over at SSM Health. Glad to be here. Really want to be available to answer any questions about some of the discussion that went on with the last board meeting about access, what kind of populations of patients that we take care of, et cetera, and would be happy to answer any questions on that. I think we do provide a significant portfolio of care, and mostly tertiary and primary care. When we do need to get into more of the coordinary care, we have collaborative agreements with UW and actually work with them quite closely on many disease states as well.
Thank you, Dr. Adden.
Yep.
And beyond that, I know that Deanna, from the, I'd say, clinic standpoint, had some specific items to expand on, I'd say, from a cultural standpoint, I think that spoke to Dr. Ottenbaker's update as well. I don't know if you want to expand on that, Deanna.
Sure. Thank you for having me. I'm Deanna Hahn. I am a director for our SSM Health at Work program and manage a number of area employer clinics. And I just kind of wanted to talk just for 1 minute about our clinics are extremely empathetic to all groups of people and populations. Specifically, I think one of those populations that was brought up at the last meeting was the LGBTQ plus population. We understand how difficult it can be for those folks to navigate healthcare, and we strive very much from a cultural feel heard, feel respected, and we're able to help them navigate through the healthcare. We care deeply that all of our patients feel that way. And I know that a lot of providers, or all of our providers, staff, and leadership across SSM really feel the same, but it's definitely a huge part of our culture in our employer clinics for sure.
Great, thank you.
Mike, from the health plan, I know that there were multiple things that you had been tasked with, but ultimately, I don't know if you want to speak to some of those.
Well, thank you for the opportunity again to be here. There were a lot of great questions that came up at the meeting last week, and what we really wanted to do is a lot of clinical questions, a lot of care questions. And what we wanted to do tonight is to make sure that we have representation from a clinical perspective to answer those questions, to meet the needs of the individuals that ask them. So I just want to reinforce, very excited to be here, and we brought our medical representation from the health plan that can talk about a lot about the care coordination that we have with our plan, with our providers. So they're also in attendance.
Great.
Thank you.
Yeah, thank you, Mike.
Go
Go ahead, Al.
I was just going to say, I know that you there were questions and there were responses. So in terms of having any of those specifically addressed, I don't know if you want them to dive into those specifics as well.
I want to open the board up for a conversation first, Al, and I assume that they'll come up, but I know them and have them. So in the event that they don't resurface themselves, I can ask too, so that our SSM folks can have the opportunity to respond. I really just want to say thank for all the friends that you brought with you today, Al. I appreciate it. I think obviously this is a really important decision for us to make as a district. I mean, we're a business, but we're the business of people, right? We're the business of kids, we're the business of staff. And so it's incredibly important that we make sure our staff's well taken care of. So I appreciate you all taking the time out of your evening tonight to answer our questions and spend some time with us. And with that, Rochelle, I see your hand up, so I will let you kick us off today.
All right. Oh, am I on?
Oh, you were, and then you.
Oh no, am I unmuted now? Okay.
Now you're back.
Great. Okay. I'm just going to ask a couple of questions to start out with. I have a ton, but I'm going to start easy. Couple of thoughts. Well, let's start with two. Deanna, yeah. Okay. You were able to talk a little bit about what we do for, or what you do when it comes to gender affirming care. And I'm just curious if we have people in our district who are already kind of planning on having surgery, and it doesn't even need to be just gender affirming care, but that's kind of a unique situation for, I think, SSM. How does that work if they're already in the books and with another carrier? When they now, if we were to switch, would they be kind of starting from square one again, or will it transfer?
Thanks. That is a very good question, but probably not one for the employee wellness clinic, unfortunately. Because which is totally fine, because by the time someone is in the middle of getting surgery and all of that kind of thing, that's something that we hand off. So I'll hand that off to either Dr. Ottenbaker or the Dean Health Plan folks.
I'm also trying to, I apologize in advance as I navigate, but Dr. Gloria Schenker, our medical director, would you like to address that question? I believe you're on.
Oh, hello, can you hear me?
Oh, there you
Oh,
are. Yep.
sorry. I was fighting with the mute and unmute button. Looks like I won for now.
Congratulations.
So, hi. Very stressful. So I'm Gloria Schenker. I'm an internist by background. I've been with Dean Health Plan and then with Medica for 10 years total. So just so you know, part of what I do with the health plan for these 10 years, part of it is working on medical policy, but then also looking at specific member requests. So when someone submits prior authorization, I'm one of the team that looks at those requests, look at the policy. If something by chance is denied, I'll have that conversation with the provider. So I'm well versed on that. When someone is coming into the health plan brand new, like let's say 1/1/25, and they have their surgery scheduled already, let's say at UW for, I don't know, January or February. Part of what we do is part of transitioning to a new plan, but basically prior to that 1/1 date, those members that are currently enrolled in care will have the opportunity to spell that out so that we can make allowances for a period of transition. So someone that has their surgery scheduled already for January, February, whatnot, we wouldn't make them start over again because again, they already have that on the books. They did their prep, they've met the criteria. So there is a transition period. I will say that it depends on what services. Something like, I have a primary care doctor and my visit isn't until middle of the year. I mean, that possibly will be asking you to switch, but people that have current active care that's currently in process, that is part of how the front end works. But I do know that there is a front end process by which the members get to submit, I have this coming up with this doctor at this place. Can you please get that in the system for me?
Okay, that's great. Thank you. Can I ask one more? Oh, I'm
Can I
sorry.
ask a follow-up on that question, Rochelle? Do you mind?
No, go ahead.
That's really good to know. Do you know the approximate like length of time that transition is, or is it dependent on like the type of?
I don't know. I'm afraid. I would have to look into that and get back to you because, like I said, I see these on the back end. I'm not sure the front end.
Okay, and I'd be curious to know if it's like a standard one, or is it like, hey, we know that this procedure is really hard to get, and so even though it's 8 months down the road or 7 months down the road, right, the runway maybe for transition is longer.
Yeah, and recall too. I mean, if it's a service that wouldn't be available in network, like that gender affirmation at UW, I mean, that's where we'd be sending you anyway. So it's not like we would make you go somewhere else just to come back again.
Yeah.
So it does depend on if this is a service available in network versus no, it's not. But bottom again, because you already jumped through the hoops.
Yeah, that makes sense. Back to your side.
No, that's great. So one other additional question about the clinic. So I know that Wildwood is one of the clinics that are, if we go with Dean, folks could use. But when I called them today, they said they weren't taking any new patients. Neither of the clinics were taking new patients. So is there a plan to add more staff, or how would you handle that with having this new flow of folks utilizing your plan?
Rachel, I'll try to answer that. I mean, Wildwood is a private practice, right? So I don't know, honestly, what their plans are. I think, as you know, access has been an issue, especially in primary care. In SSM, we've done some really good things the last year, really focused on, we're almost back to pre-COVID levels of primary care physicians and advanced practice providers. So we feel really good going into 20, assuming that they struggled as well with some of the issues and the aftermath of COVID. I just don't know what their plan is as far as recruiting new providers or not at Wildwood. Yep.
Can get a turn here. I'll step back and listen.
Eric. Thanks, Rochelle.
Yeah, thank you, Elizabeth. A couple questions. I think I can get done in less than 3 minutes, and then I'll yield to the rest of the board unless anything else comes up. So I'm going to just go through a couple things that I have concerns about. First thing is which HSAs I do not think are a good thing for Dane County. We have access to the UW Hospital Services, which has very valuable resources for people with chronic diseases, people that have specific health care. And I can tell you from experience, since I have had all three plans, I've had Dean, courts, and GHC, that the Dean referral process is not easy. It is not quick, and it takes a long time. So I understand that, there's people on from Dean saying here saying that, but you should know it's not a quick process, especially for somebody that needs immediate care. It's just not. So it never has been. I've experienced it firsthand. I've also talked to people in the district that have had many issues with that. So that's a serious thing that I think the board members need to understand. The Dean people and all the representatives here are going to tell you, and they're saying that they have a process for these things. It's not quick. There is no referral process that's ever been quick in my experience, nor the experience that I've heard from our employees in the district. So that's serious. It's especially serious if somebody has a chronic disease or they have cancer and they need immediate care and they're on one insurance carrier and they have to switch to another. It's life-threatening serious, and we have to treat it like that, and we have to take it seriously. And I don't think that, chancing a day or even 2 days for a referral process or transgender care for somebody that's made that decision with their doctor, that we should be in a position that we're jeopardizing that for those people. So I was here. And also, we've asked you a lot of questions, and I haven't heard you answer one of them yet. So that makes me a little concerned. Because if you can't answer them for the board, I'm wondering, how are you going to answer them for the new members that you're going to have?
Hey, Eric,
the survey
is there a
result?
specific question?
No, I have
I
more.
know,
Hold on, give the other board members a chance, because I think a lot of this will come up. The survey results did not show any definitive information resulting in people on Dean or or Dean especially that would be switching over compared to people with GHC. We have more people on GHC. I understand the value of being on Dean. I'm not trying to belittle that or pretend like I don't understand that that's a valuable insurance plan for some of the people in the district. It is. I get that. I understand it. However, it's not a great insurance plan if you need care from the UW hospital. It doesn't work that well for those people. And that's a lot of members and employees that we have in the district. The UW hospital services provide a very valuable resources. And although you say people from Dean that you can get referrals for that, it's not an easy process. Specialty pharmacies. The UW hospital has a specialty pharmacy for specialty drugs. For certain people that have chronic diseases and cancer, you will have to get a specialty drug. You can't go to Walgreens, you can't go to GHC, you cannot go to Dean. You have to go to a specialty pharmacy. Walgreens has their own separate alliance specialty pharmacy, but UW now has their own specialty pharmacy, which is available to people on courts and also now available to people on GHC. So they can access that specialty pharmacy, get those specialty high-cost drugs, those life-saving, life-dependent drugs that they need, and they don't have to wait. Dean doesn't have that. I know that Dean doesn't have that, okay? That's a serious concern of mine. The wellness clinic, although it would, also going to be a geographical problem for a lot of people. I don't like the idea of a wellness clinic. In fact, I have something very similar to a wellness clinic at the Madison College with the GHC. And while it's beneficial for some reasons, it's not beneficial for everybody unless you're by the wellness clinic. If you live 10 miles or 20 miles from the wellness clinic, it's not going to do you much good at all, especially if you have kids that are going to school in a different district. I don't understand the value in that it's going to provide the extra value it's going to provide for the GHC employees that we have. They're on that insurance plan. Raised a non-practicing Catholic that was raised in a predominantly Catholic family with 42 first cousins, I might add, that I have, are a real concern to me. And you can't tell me that the Catholic values encompass transgender rights and transgender healthcare or abortion, because they don't, because it factual as it can be. So you can say that you're going to provide care outside or provide that care outside of the services that Dean provides. But I would love to see that happen. I've heard horror stories, in fact, from people in the district about their concerns and crying to me of how scared they are. What right do we have to make a decision between a doctor and a patient in any circumstance? Zero. No right. This is not my decision. That's a doctor and a patient. And I don't want us as a board to make a decision that's going to disrupt that patient-doctor confidentiality and healthcare that they have to make. And then my final question is for Tanya and Kristen. Why didn't we get an option for both plans? Is both plans an option? I would like to see that, because the 5% increase from GHC doesn't seem like it is that outrageous. Rushed. It feels really rushed to me. And it feels like the decision's already been made from the administration side. I don't like the fact that we're feeling rushed into this. I understand there's a timeline, but I feel like I'm being rushed. I feel like this decision has been made without consulting with the board, between brokering deals that I have. I'd love to get more information about how that works, because I'm wondering, did GHA not competitive? Well, if it was 5% or 4%, to me, that might be competitive, right? Did courts make an offer? I didn't see that either. So I would like to see, more options and more information about other GHC and courts plans, in addition to maybe potentially keeping the people that are on Dean in some way, with even the HSA, if that's possible. I'll yield my questions. I don't think anybody needs to answer them now. Those are my concerns. Those are the concerns of the families that I've talked to. I've had families crying to me. I've had families scared to death, quite literally, of this change. And there is no way to support this as it is right now. I just can't do it. And I don't think there's going to be anything that anybody's going to say to change my mind on that. And so I will listen to the rest of the discussion. So
I appreciate that, Eric. And I think there are actually like a iterate, just because I think it'll be worth getting answers to those. One obviously is around gender affirming care, which we've heard about already, but I think good to reiterate that. Another question that has come up a lot is reproductive health, as you alluded to, Eric, and that came up quite a bit at the meeting on Wednesday. I think the question around specialty farm is a good coverage question that we should ask. And then I know that Tanya and Kristen had shared previously around kind of the dual plan status quo option, but if there's any additional context that you would want to add there, Kristen or Tanya, that would be helpful.
Yeah, I guess I just want to point out that, we did ask GHC example that Tanya did show, with a 52% increase for those on Dean and a 5% increase for those on GHC. We also asked GHC for a high deductible HSA plan, and they were not able to provide. This was not something that was any sort of big scheme or plan by Dr. Frederick or I to push Dean in any way. I have no affiliation with Dean. I never been on Dean before. It truly was the best received as far as moving forward. In terms of the time frame, this is a normal renewal schedule where you don't have your renewal numbers until when we got them September 17th, and the reason being is because they want to get all your claims in so that the actuaries can do their job and determine what the premiums are. So we did do our due diligence. Al and USI are very versed in Dean County and the different options and the different vendors. We did vet those, and the option that we're proposing to the board is one that we're just trying to provide options for the district to take more control over health costs that are just escalating at a point that are negatively impacting our bottom line. Understand if that's not something palatable for the board, but I wouldn't be doing my job unless I did bring forward a plan and a design that I've actually implemented before and have had great success with, and a lot of other Dane County school districts have, and it's the direction a lot of other Dane County school districts are heading. There are very few, if any, that have dual choice because it's just not affordable and sustainable. We're just trying to present an option to help the district in the financial situation we're in. There's no other ulterior motive here from our first 100 days in the district. Just trying to help.
Great. Eric, did that answer your question, or did you have a follow-up for Kristen?
Oh, okay. Thanks. I was muted again. No, I guess my follow-up is, you say non-competitive, but are you saying that GHC presented a plan for 5% and you consider that
The
non-competitive?
non-competitive portion is the fact that almost 50% of our population is on Dean, 216 versus 236. So only a difference of 20 people, and half of our population is going to experience a 52% increase in cost. We thought that would be something that wouldn't be fair for half of our population.
So are you saying then, Kristen, that it's not possible to do both plans? Does Dean need a certain number of people in order to do that plan?
No, we have the status quo plan.
I think what Eric is asking, if I'm understanding right, Eric, is so right now the premiums that you're sharing for Dean is total Dean takeover. Those numbers change if we're side by side with GHC, correct? That's what you're asking, right, Eric? Like, can we keep a total takeover plan and use an option?
Yeah, because of the people, do you need to do a total Dean takeover in order to get that same plan?
Yeah, the HSA clinic, that stuff.
Yeah.
Al, can you talk a little bit about those when you gathered the proposals?
Sure. So with the framework of the ask in terms of clinic, in terms of high deductible and whole 9 yards, in sending out the same request, the bottom line is, first and foremost, the status quo plan is what it is. That doesn't change if you don't change anything. Those numbers are what they are. The question is, in order to align with the clinic, in order to align with the high deductible, in order to align with the overall proposal that's on the table from Dean, the aggressive package that they packaged together, understanding they'd have the entire population so that they would work with their specific clinic offering. At the district size, in combination of all the above, to make the numbers work, to sponsor a clinic on top of the dual offering, there would be additional layers of cost on top of that. So, when you speak to the different models, the high deductible would allow you to remain somewhat cost neutral by including the clinic. Hopefully that clears it up a little bit. Yep.
Tish, can you unmute Eric?
And the other thing is,
can we fix this mute thing? Because board members are going to need to talk. We shouldn't have to be, if we're going to be muted every time a board member wants to talk, that's a problem. To respond, Al, are you saying that Dean can't do the plan unless they have 500 or what we probably guess 450 people? They can't. Why can't they do it with 200? I'm not an insurance guy, so I don't know.
No.
Why can't they do it with 217 people?
I can share what the response was.
what if we take out the clinic? Could they do it?
So the rates would change, and the reason the rates would change, and this, I'm speaking on behalf of their response from their proposal as well as in talking back and forth. And this isn't different from Dean to any other carrier, but by having the entire population, they understand the entire risk. When you're dual offered, the concern so as a result, they're going to rate with oftentimes more of an assumption that, we could take on the high risk, but in the end, the less risk would go away. And to your question, when the premium's higher, they understand that people are paying more to access them when they're paying more, probably because they want and need additional care. So
Yeah, it's more expensive, right? Al, it's the bottom line is that like you could do it, but it'd be a lot more expensive.
correct.
Elizabeth, I want to yield to other board members, and you can circle back to me after this one.
Yeah. Okay, sounds good. All right, Janice, I think you were next.
All right, a couple of questions. First of all, I really don't understand at all how suddenly one of our, like, I don't think that's ever happened. And I don't even understand how that's reasonable. So can somebody explain how Dean would be going up 52%?
The summary would be their rates didn't go up 52%, but based on the contribution level of 90% of lowest cost plan, when Dean rates go up, call it 9%, paying the difference between the two, the impact to the staff member to cover the difference of those two, then the impacts, that 52% number that you're looking at.
So they went up 9%? Okay. So Dean is the one that went up more, and we're going to potentially go with Dean as a sole provider. Then what's to keep Dean from being like, now we can just raise the rates as much as we want because we're the only game in town?
Two things. They do have caps for year 2 and year 3. And second of all, Kristen, your main strategy behind this, your objective of consolidating, number 1, number 2, improving population health, and lastly, seeking to go toward a path of self-funding where you're not dependent upon the carriers. The conversation there is specifically with Dean, their provider contracting statedly speaks to they will afford the same pricing with the providers on a self-funded scenario. In other words, as a health plan. So in other words, the charge fee for service equivalent on self-funding is comparable to their fully insured. And as a result, it would have allowed the district to take control of their cost in a self-funded scenario versus the fully insured and being at your term, I think, was what prevents them from doing whatever they want. And the short answer would be you control your premiums in much more of a scenario of self-funding.
I don't know if it would be necessarily my strategy. It was in consult with USI, something that I've been involved with before. Population health is important. I wouldn't not consider the importance of that because I've seen it firsthand. Right now, we have no ability to get reporting on our population health because we have 2 different entities that they don't speak well with each other, so we can't really report out on what specific needs are there for our population. So that's one issue. And then the second is just focusing on wellness care. And sure, not everyone participate, of course, but again, there's some people that are in condition where you can't meet every single person's need. If you look at the entire population and what is best for the entire population. It's really important to be able to get as much control as we can as a district, and as long as we're fully insured, the district, the insurance companies are making the rules for us. And so this is about having more control over what is our plan design need. Do we have musculoskeletal needs? Do we have a lot of back injuries? Should we have some kind of a program focused on that? Some PT that's in our clinic. I mean, there are just so many different things that we can change and have the flexibility to navigate when we're not under the control of an insurance company. But again, you know, not my decision to make, just my job to make sure that you're aware of the options that we have. And like we said, we have the status quo is there. We can certainly move forward with that. It's just a matter of, you know, all those choices have consequences. And that choice will lead us farther away from the path of having any control over these costs. And I don't agree that we can't ever have any control over the costs of health insurance to the district, because for 8 years I've seen it differently.
And Kristen, last point to that, when we look at the responses we received, specifically if that is the long-term play desired, for example, in your prior experience, or you went, I don't remember how many years you stated that you went without having to change your funding levels in that model. But the bottom line is, in order to get from there to here, having a comparable initial contract on the providers is a key piece, as well as having an integrated proven clinic model in the area. And that's the two probably biggest obstacles, back to one of the original questions at this point. If you want to go down, you know, that progression and have that result, the UW has a significantly higher cost structure to go toward self-funding than what you would have, first and foremost, with GHC or courts. And second of all, there's not the same district models proven with the clinic that districts have done throughout the area as well to have demonstrated results. So I think those were a couple of key parts of the question as well.
Exactly. Janice, did you have another question?
Yes. Sorry.
No, don't apologize. Go for it.
Okay.
And we'll go back.
So we are a district that is in 2 communities, and if we're having a wellness clinic, A, where is it going to be? And B, there's like a cost to set that up, and then there's a cost for staffing it, and like those are all costs. So like say it's in Monona, then all the people from Cottage Grove need to come to Monona. Say it's in Cottage Grove, all the people in, you know what I mean? Like it's not as easy as if we're just one district in one city, like we're one district in 2 cities. And then the other thing that I feel really needs to be addressed is we do have retirees who retired before 2016 who are still on our health insurance, and they have this benefit that they earned. And we have always had dual choice, and we have always had the ability for people to choose their doctors. And these people like were kind of, you know, that was the thing. Like when you retire, you get this. And I really feel like we need to make sure that we make that work for those people. And I do not understand how that's going to work for them with a high deductible plan.
Is it okay if I jump in on the question of the clinic? Okay, so we have there are in 2 different districts. I actually successful clinic that actually has 6 districts participating in it, and it's centrally located about 15-20 miles away from all of them. And so, and it works. So we go on site to the different schools. We do on-site pop-up clinics at the district office, at the schools or the district office. We try to bring healthcare as much to the staff as possible. And then we also have obviously a virtual option is available with those same providers through the clinic that can reach people for a multitude of different things, including lifestyle coaching, weight loss, anxiety, and we can also help you navigate that healthcare, to help you with those referrals. You have a huge advocate in this clinic for staff that are invested in getting you what you need. That's what we're here for. That's our sole purpose of being, is to take care of this population and make sure you're really getting what you need. And also we can be flexible and pivot and turn towards health need. We can run targeted incentivized plans or initiatives and all of those kinds of things too through the clinic.
So what does it cost to set it up?
Kristen, do you want to walk through those numbers, or Al?
Give me a second. I know that it was, Kristen, you have that as part of the entire, that was part of the entire proposal.
So yeah, there's a cost per month for operations, and I want to say it was about $28,000 a month just for operations. There is a setup cost that we're still, obviously it costs, what it costs to. I think there was an estimate given from one of the previous clinics that was around $30,000 to set up. But the actual cost of operating and staffing it are included in all the costs.
So yeah, Kristen, I'm sorry. It's about 24,000 a month for the clinic.
The district pay?
Yes, it's a fixed cost, so we pay that monthly. And so that's another reason why it's beneficial. Staff can use it, particularly for those urgent care needs. $20 cost copay, whereas now if you go to urgent care, it's hundreds of dollars. Labs are free. You can get your labs there, even if you go to your primary doc or a specialist and they ask for labs. You can go there and get your labs for free. So really easy access for kids that need sports physicals, vaccines, that sort of thing. So a lot of benefits.
And I just want to clarify, we wouldn't be sharing with another district. It would be Monona Grove specific. We talked about doing a interim setup maybe at Maywood until we find the location. And, 7 miles between Granite Ridge and district office. So, I think people travel. I'm not sure that if the 7 miles one way or rises to the top of the conversation. I think it'll be more about getting a facility that, if we were to go in this direction, is meets all the needs from a medical perspective.
And Khalees, do you think maybe you could speak to, we recently just went through this journey together, maybe speak to how it was getting it set up and the cost to the district?
Yeah, what I can speak to, Khalees Hurst, I help support districts in their wellness coordination for their schools. I also work for Middleton Cross Plains, and we recently opened a clinic. Middleton Cross Plains, we also have 2 communities, so unique, just like Monona Grove. Our clinic is located kind of in between the 2, actually has a Verona address. But it is within 12 minutes at the most to get to the clinic from any of our buildings. Some of our employees certainly don't live in the district, but the quality of care that they can receive and feel and receive at the district is unparalleled and worth a drive, if that's what it takes, or a little more time. I know personally, I'm probably about a 25-minute drive from the clinic, and my youngest daughter will ask specifically, can I go see our provider? Because she has a relationship and she cares, and it makes a difference. The clinic is truly about getting you connected with the right care at the right time in the right place. So if it's not something that the clinic can provide, it's connecting you with that behavioral health specialist and getting you in sooner than if you were to try and navigate the system on your own. There's, anytime there's change, there's going to be disruption. And by having the clinic, there are so many benefits to that your staff will feel. beyond just, you know, going and getting the care. The care is just so above and beyond. So I think it's important to know that when we made a change from dual choice to single choice a few years ago, we didn't have a clinic and it was really hard. And I'm not going to say that it wasn't. If we had made that shift with a clinic, it would have made the biggest difference. Being able to access the health that they couldn't normally access without Deanna's, what you were looking for, just in kind of giving that perspective.
Then
Oh, go ahead, Jen.
it just, if I'm doing the math, it's like $288,000 for like the year to run the clinic, plus at least $30,000 to set it up, which is $318,000, right? So that's what we would be paying for the clinic. And how much is it to just keep what we have right now?
So I think
Status quo.
from a Kristen standpoint, the cost of that you just identified is part of the proposed cost.
Right, so it's part of the cost, so it's a lower cost than what it's current. I mean, if we went with status quo, it adds $355,000 to our cost. This proposal keeps, well, if we go with the additional HSA contribution, that costs $173,000 more. So it's less cost to go to a clinic model than it is to stay status quo.
So we save about 175,000 in previous expenditures.
And then retirees.
Yeah, so retirees that are on our plan, that the district is paying for a partial of their benefit, they would get a contribution to an HRA if they chose the high deductible plan. And they have an option of the point of service or the traditional HMO. So there are out-of-network services available. So like they, have this relationship, want to continue with that provider. It's a higher cost, but that is, something that we've heard that people are willing to pay a higher cost if they can stay with their provider. So, we have the 4 different options. We focused on mainly the high deductible HSA plan because that's sort of the base plan and that most people were on. But we've always offered all of these other plans, and that's not changing. It's just the one carrier, but you can go out of network with a point of service or PPO plan.
But if it costs more and you're retired and you don't have additional income to spend, like you're kind of stuck, right?
It just depends on, prayer. Is it that important that you're willing to pay that much more to continue to see your doctors out of network?
Okay, and then last question. I watched the meeting. Apologies for not being there. I was out of the country.
Don't apologize. You're on a great vacation. Never apologize for vacation.
And there was a discussion about like people getting their high deductible like HSA paid in 4 different installments, but like I know some families would go through that all in January, like in the first month. And so I was really disturbed to hear the answer that if you were having a procedure in January or February that you could go on a payment plan, like that's not okay. We need to be able to get people their whole deductible. Like if they need it in January, we need to be able to get it to them in January. Like going on a payment plan is not insurance. So we need to resolve that issue, and then I'll hold any other questions until later.
I appreciate that, Janice. I don't know, and Kristen and Tanya chime in if I'm wrong here. I don't know from a cash flow perspective if that is possible. Like I understand that would be ideal, but I don't, my understanding is that we would not have the cash flow to front load everyone's HSA contributions.
Yeah, we can't pay everyone's, and I don't know that it would make sense to pay everyone's because there wouldn't be, everyone wouldn't need, all of the HSA up front. From a out of pocket immediate need. We addressed the prescription, high cost prescription with the request for an accelerated HSA payment. Being on a payment plan, I don't think is necessarily a bad thing, Al. It seems like it's, something that is customary, that is done. It's not like there's an interest cost to it. It's just, this is my schedule for being able to pay it, and you agree with the provider on that. Am I?
Yeah, no, I think that's a fair statement. And I would also say that in large part, your purpose of making the prescription exception is because that isn't that in many instances is not an option. And as a result, that's when we have seen exceptions like this made. But to your point on the medical side, it's pretty much a standard, especially with the HSA model.
I see Susan and Peter, I see you, and Dr. Schenker has had her hand up for a while, and she's a guest in our space, so I'm going to let her say what she needs to say, and then I will switch to you next, Susan.
Thank you so much. Sorry about that. So two things that came up way earlier that I just wanted to speak to just real briefly. So Dean Health Plan, be aware, does have a specialty pharmacy, and it's Lumicera. And I know that because I have a family member that is on a specialty rheumatoid arthritis drug. We get it from Lumicera. It's sent to the house every month. It works great. One thing I was really impressed with Lumicera specifically is when we call them to get set up, unprompted, they said, hey, did you know that the drug company that makes your drug has a rebate program? And they gave us the phone number, said, go call them. We called them and got our copay down to $5. So did Lumicera need to tell us that there was a rebate program we could use to lower our copay? No, but they did. So I'll forever be grateful for that one example of them going the extra mile. Regarding the prior authorization, so recall, just to make sure everyone on the call is aware, there are, federal and state turnaround timelines for how long a prior auth can sit with the health plan before you do have to turn that around. So, not saying that someone may or may not get an answer for prior auth in one day, but certainly they don't linger since we are held to a standard as far as when they need to be turned around. And same with GHC and all other insurers. We all have a turnaround timeline that's the same. And the last thing that may have come up previously, I just want to reiterate, we at the health plan, Dean Health Plan, do have a really unique relationship with SSM that I don't know that you'll find everywhere. So our health plan is pretty well connected with the staff. So a good example, a few months ago, one of the pain management providers contacted myself and said, hey, you have a policy for this prior auth for this injection. I don't think it's doing what you want. Here's some situations in which perhaps the criteria could be looked at or tweaked because it seems like patients are getting caught up, and we're responsive to that kind of thing. So we do have a way to kind of get direct input from your providers to kind of get that personalized feedback and look at the big picture. And am I, biased as a Dean person? 100%. I've been with Dean for 10 years. I'm as biased as they come. But I will say that from what I've seen from our, physicians, my physician colleagues, our case management staff, our nurses, they really do care and do go above and beyond. And when something does get denied, it's not for that was the quick and easy answer. It was because we looked at it and look, this just doesn't follow evidence-based medicine. This just wasn't the right thing to do. So I've seen that time and time again. So, I've been with Dean for 10 years because not only is it a good place to work for, but I truly believe in what they're trying to do, which is getting people the care they need. So I just wanted to reiterate that if that hasn't been made very well clear before.
Susan.
I have several questions even after our meeting this week, and I really, really appreciate the staff that's been here to answer our questions. And I sincerely appreciate the work that Tanya and Kristen have done to try and help us make this work. And I am part of this that brings me to these questions seriously is my background and the work that I've done in the healthcare systems in Dane County. So my very first concern continues to be, and it's already been stated, and that is providing access to the number of people that will be transferring into this program. And you pretty much answered that and spoken to that, but when you look at that number, and I also understand that Deerfield School District is making a full transition to Dean, and there may be others, that's a significant number of people that you're adding to the process. I also understand the idea of putting in a clinic. I've been talking to Dan Olson, particularly about just initial assessment for mental health for students in the schools. And so to actually see that might happen. So one of my questions, and maybe want to make a note as I go through them, is who would staff that clinic? I know if it's an NP, it requires a collaborative written agreement with the physician, and they need to be providing supervision. And having reviewed the Medicare the requirements for Medicare and the reviews of several health plans within Dane County in terms of the documentation of physician supervision, those are fairly strong criteria that need to be met. There's also language about if it's a nurse practitioner, that they're not considered a primary provider. And so anyway, it does raise questions, but it is nice to have, like when I was growing up, we had a nurse in our school. But that transition of when this person needs more care, then what happens? So that's also a question. And then I have some moderate to relatively serious concerns on an HSA. And that's one of the reasons when group health didn't offer a high level, high deductible health plan, then they can't offer an HSA because that's required to utilize an HSA is a high level deductible health plan. So if you go to the regular Dean plan, you can't use the HSA. It has to be very clear to staff when they're making choices whether or not the HSA is going to be a part of that, because that session, you cannot have any other health. I'm reading the IRS requirements. You can have no other health coverage. You cannot be enrolled in Medicare. For our retirees, that could be an issue in the transition. And you cannot be claimed as a dependent on someone else's tax return. And then the other concern I stated before, and I continue to have, is the level of high quality medical and particularly surgical care that may be necessary. So if you're talking about needing a kidney transplant, then what you've talked about is that would be a referral out. That's a little different. So one of the struggles I've actually seen in documentation is the referral being made, one, and two, the referral being made in a timely manner that gets them into the other systems, such as the UW. There occasionally appears to be some reluctance, if you talk to some of the patients, about getting that transfer, for example, to the university hospital. So I still have questions about that. Again, specialty care, the number of orthopedic surgeons, plastic surgeons, surgical oncologists, cardiac surgery, transplant surgery, and mental health providers. And it was very helpful to understand that if you have a child that needs to be admitted for mental health services, such as they had tried to commit suicide and they really need to be in a healthcare environment, they will go to Rogers in Milwaukee. That's a concern. And it may not be for everybody, but it would be one, if it were my children, that I would be concerned about, particularly if you have more than one, because it makes it difficult to stay with that child in Milwaukee. And then again, who staffs the clinic? And then the other concern,
Well,
I
I
just have one
actually
more.
think the question about who's staffing clinic from a credentials perspective is a good question. So I'm wondering if maybe we want to pause and get that question answered.
Yeah. Yeah, and I can
Okay.
jump in on that. So we do staff these clinics with nurse practitioners or physician's assistants. That is the most cost-effective way of doing this. And that licensure can take care of about 95% of primary care. We also are not a primary care provider
Right.
per se for our patients in our clinic. We can be a primary place of care, but we work very closely with collaborating physicians, and all of our advanced practice providers do have an assigned collaborating physician that all of my providers meet monthly with that collaborating physician. They have a very good relationship with that physician. That physician does review charts and sign off on them per any regulatory requirement. Dr. O, jump in case I'm.
Well, no, yeah, I mean, what I would say too, right, is that every person would still have a primary care physician as their primary care, provider as well, so that if something needs to be escalated, they hopefully do have a relationship in the more the formal sense of an extension of that clinic, which would be their primary care provider. And so it's a seamless methodology, and it works quite well. And as they've all said, I mean, the great patient satisfaction here, efficient, timely, but also knowing that you have the background of the physician services if needed to escalate appropriately.
Okay, well, I appreciate that. I think it would be helpful to have just a light survey, because I have not gotten the feedback that it's seamless. And I also looked at the list of some of the things that you actually do. And you talk about virtual, and you have somebody with an ear infection. Well, again, I just want to be very well understood that that can't be done virtually. You also can't do a breast exam virtually. I just
Susan, I absolutely, right? I mean, and that's kind of common sense, right? And what we do for a living in healthcare is our providers are all credentialed and experienced in providing appropriate healthcare at the right place and at the right time. So yeah, you're absolutely right. A ear infection would be silly to do virtually, but there are a lot of other things that we can provide virtually.
Yes. I understand. I think that's, again, it was one thing in the middle of COVID, and it's become a little more difficult in terms of reviews to have that work well. And then the only other thing is more of a general concern, and that is because of the timing and the need to work on this really incredible, disastrous budget. And I can't thank Tanya and Kristen enough for the work on that. I continue to feel disadvantaged by not having some suggestions for major budget decreases, such as for capital improvement projects or things, and having to be comparing that with this at this time. Understanding there's a little bit of a force into this. If there's any way we could have bought time, like made the major change in a year, or even 6 months, I think that would have helped us all dramatically. So again, I appreciate you listening.
Thank you, Susan. Peter, you're up.
I want to thank everybody here who's here to answer our questions. And I appreciate them. Let's see. So where to start? First of all, Al, you mentioned that this plan has 2 to 3 year 2 or 3 year caps in place on the rate increases. Is that true? And what are they?
So on the insurance portion, it's 7.5 for 2026. And a second. Chris, I'm looking through the language to confirm what the second one is. Is Chris still on?
Kristen?
Al, did you say Chris or Kristen?
Chris Sinetti, sorry.
Oh, that's what I thought. Yep. I don't know if she's on.
No, Chris is...
Oh, yeah.
I think so.
I don't know if she can unmute though. There you go. Can someone unmute? Tish, can you unmute Steve Sinetti?
I'm looking for the language.
Chris is shouting at her Zoom right now.
Maybe they walked
Exactly.
away to grab a snack and we're all just awkwardly talking about them.
So it's 7.5 in the in 26.
Oh, so I'm sorry.
And there's another cap for 27, but we don't know what it is.
No, so this is on so that was blending the entire spend. So just on the insurance spend, which again would be about, call it 2/3 of, somewhere around 2/3 or 70%. So if you just look at the insurance portion, all right, 2026, just the insurance portion, 10.6, and 2027, 12.6 on the insurance portion. So you blend in all the other costs, that becomes less, but 10.6 and 12.6 to answer the question of.
So over the next 2 years, a 22%, potentially 22% increase. A maximum of a 22%. And after that, there's no
caps,
right? Yeah. In your experience, what's the value of having multiple providers like we have competing for the business when it comes to controlling costs?
I'll say the last 20 years, it's been up until the last 4 years, pretty exceptional, to the point that in many instances, carriers would bid against each other while dual offering and ignore a lot of their loss ratio. Once carriers started going out of business and the cost became such, there's a large part of the reason that you see districts consolidated that are of the similar size. Does that answer your question?
Well, you tell me there's a phenomenon, but not really.
Not in the last, that phenomenon went away in the last however many years.
So in the last 4 years, when districts have been consolidating into a single provider, how do their first year costs compare to subsequent year costs? Somebody's been there for 5 years. What sort of increases have they been seeing?
I'd say trend would be the best answer to that. So in other words, in that 5 to 7 range. And that's specifically on the insurance cost.
So you're not seeing any moderation of sort of increases. You're seeing a one-time drop in costs, and then we see sort of similar increases in overall costs that we've been seeing for the last several years, right? We're not in the long term. We're not sort of bending the curve.
Well, I think that goes back to the areas that it bends the curve specifically include a combination of the clinic, includes a combination of I'll call it the clinic and prevention incentives, And lastly, when you have HSA models, specifically I think speaker we had 2 weeks ago, there's multiple districts, smaller districts, much smaller districts that went many years with, I'd say, an average of anywhere from 2 to 4%. So when you combine all of the above, not just consolidating, it outperforms trend.
We talked about a self-funding model. If we can talk about that a little bit more. First of all, if we're self-funding, what sort of infrastructure would the district need to support that?
Kristen, do you want to? Oh, sorry. Kristen, do you want to jump in on that one?
Sure.
So if we're self-funded, we need to get stop loss insurance that covers us, at the high end. We also would have funds set aside in fund balance that would bridge the gap between what our premiums are and that stop loss, because the stop loss is typically at the higher end. And in years that are good, we use that, lose portions of it to build that reserve for self-funded insurance. And in years that are bad, you can also use that as a buffer to help support any, fluctuations that you might see in terms of premium equivalents that you need to charge and the impact on employees on that.
What other resources will we need that we currently don't have to do that, to support that model?
Well, we have a third-party administrator that would obviously administer the claims, but that's really it. We have a third-party administrator. We have our broker with USI that helps us, strategize in terms of what our plan design looks like and different incentives and things we can do to increase our population health and get control on our costs. But it's really the cost of the third-party administrator and our stop loss. So we have aggregate stop loss and individual stop loss.
Kristen, there's a little noise in the background where you are. I don't know if you could get a little closer to your microphone or something. You are it's a little bit staticky, a little hard to hear you. So we talked about if you're self-funded model, then you have tools. What are the tools that you have available in a self-funded model?
So in a self-funded model, we could direct contract with, let's say, a physical therapy company, so that we could offer lower cost to us because of our population went other places. We could direct contract, negotiate a fee for that service, and then pay an incentive. So they wouldn't have to go there, but if they went there, and we know that their quality of care and their costs are competitive, we could pay them an incentive and still reduce our costs overall. So, those are the type of things that give us that flexibility to make unique adjustments based on what our needs are. We can't do that now. We basically have a plan that Dean designs, and we go to Dean providers, and it's, that's what it is. For self-funded, we can look at different formularies. We can look at different prescription benefit managers that fit better with our population and our needs. There's just so much more that we can do.
Who would be making that kind of decision? People in the district, or our third-party administrator, or who would be looking at? Because that would be a lot of work to say, oh, we're spending a lot in physical therapy. It might be good to get quotes to do this. Who would be making that kind of decision?
So we work with USI, and we have the reporting capabilities to tell us that our musculoskeletal spend is going through the roof. We're doing a number of back surgeries. We need to have better, PT care, or, those are the things that we can do to even identify what do we need, what would be most effective for our population. And then USI would help us with that direct contracting.
Okay. Yeah, I'm just trying to understand the model and where it is that there's cost savings other than, reducing care. Not saying that we do that. I'm saying as soon as you say, well, we can save money in healthcare, you think about ways that people are thinking that they're reducing care. So I'm just trying to understand.
Well, one of the examples that that I have experience in is with musculoskeletal and knee replacements. So, we have the data on success as far as knee replacements and infection, follow-up, all that stuff. And we can identify the providers that have the most success. And the costs vary. You can get a knee replacement from someone that costs $60,000 and another that costs $40,000 that has better care, lower infection rates. And wouldn't we want to be able to direct our members to that?
And
rather than have them, these are all the providers in the network that you can choose from. And
absolutely. Yeah. Absolutely. I just hear you saying making a lot of, I believe that we are in education and we're talking a lot about, medical decisions. And I'm just questioning who has the expertise and how we find the expertise to make those decisions. Because I don't think that, I don't think we have it in-house. I don't think it's something you want to bring in-house. It's just how do you, that decision process is complicated. And
I hear the hesitation from, so many board members at this point in time. I'm not even comfortable with the board, voting yes for this. I mean, I just think there's too much concern and trepidation, and I don't want this to be like Kristen's plan. And this was merely a trying to be a creative strategy that I believe would be a more robust benefit. But I don't know that this fits with our district. And I feel really uncomfortable at this point. I'm being accused of having some, nefarious, ties to Dean. And I don't. Like, my only intention was to do
Kristen,
district, and I'm feeling really like this isn't this. I almost want you to vote no at this point because
let me just
I was just trying to do a good job.
No, Kristen, can I jump on that too?
Wait, stop.
Yeah,
I'm first.
That's fine.
Kristen, I appreciate. I just need to say directly to Kristen before we say anything else. If you are not getting shut down by this board occasionally, you're not trying hard enough. Okay, so I am very pleased. I am very pleased.
It's fine if I have no problem with the board not agreeing with me. Where I struggle is when I get accused of doing something, for other reasons.
I very much appreciate that you've gone to this effort to bring forward a plan that saves the district and everybody a lot of money. Obviously, it's healthcare. Obviously, it's going to be a challenge. It's going to be a difficult thing to do. But getting us to this point, you have certainly done your job, and you've exceeded what I think is, you've really done an excellent job. Your exceeds expectations for bringing this forward, regardless of where we end up deciding on it. So I really appreciate. I'm just trying to say I really appreciate what you've done.
But at this point, I just want to officially say I'm retracting my recommendation, and we should just stay status quo. Officially, okay. That's my statement.
I don't agree, Kristen. And I haven't spoken that much because I obviously was virtual at the board meeting last week too. But I like this plan. I think that it has major benefit for staff. I think it helps to support where we need to go from a financial perspective, which, from my opinion, is that's this board's big. We need to move forward on that. I also have seen, right, I think many of you know that worked at the national level, looking at a variety of school districts all over the place, and I've seen the benefit to Wisconsin thing. This is a trend that's happening across the nation, and you can see the benefits to staff wellness and population health when folks have regular access to I mean, you are welcome to retract whatever you would like to retract, Kristen, but this plan to me, it makes sense. Right? I understand that it's not perfect. I understand that there are folks for whom there's a lot of concern. I think money is emotional, health is emotional. The combination of money and health is emotional. The American insurance system and American healthcare system in general is exponentially flawed at best, right? So I'm not surprised that there's a lot of emotion coming out. And I don't want us to lose sight of the fact that I actually think this is a good solution or part of an important solution to not just the budget concerns that we've had, but long-term sustainability around health, as well as actually improving population health of our school community, which will have a direct impact on staff morale, staff wellness, and student achievement, right? Because we know that staff educator health and wellness has a direct impact on student achievement as well. And so I think it's a good plan. I like the plan. And I think that there are others in the room that do too. And I think asking questions and having those kind of through lines are really important for.
I have one more question.
Yeah, go ahead.
So, I think that there are a lot of things to like about the plan, the clinic, I think on average, the average person in the district will see the average staff, but person in the district will see, when I think about the look at this, we'll see lower costs. But there are some holes, then there are some concerns. And one of them is, well, actually, I'm sorry, I misspoke. I have two questions. First one is, can someone please explain to me this issue with adult children on your plan who can't use the HSA? Can somebody explain the details of that? Number one, who it covers, who it doesn't cover, et cetera. Well, actually, let's do that question first, if somebody can answer that.
Yes. So can they use their tax dollars for
the HSA?
Can they use their HSA dollars for somebody? So the bottom line is there's a lot of confusion on that, obviously. And the first part of the question that we had received was, will those dollars accumulate toward the deductible? Short answer is yes, it will. So all those claims go to the deductible. That's a non-issue from the carrier side. The next question is, can I use the HSA dollars? And the short answer is, it's up to the employee how they use them. The question would be, if they were to spend it on an individual that cannot be a tax dependent. It's not a matter of whether they are tax dependent. It's, can they be a tax dependent? And if the answer is no, and the general smell test that has gone out there is, can you demonstrate that you're providing up to 50% of support if you were to be audited? And if you can demonstrate that you provide up to 50% support, you don't have any issue. If you can't, and that's, we've not heard individuals get questions, but we need to, to demonstrate complete transparency. If they can't and they were audited, could they be subject to that being, whatever they spent on that dependent would be subject to being treated as taxable income? Number one. Number two, they could be subject to a 20% penalty on what they spent on that dependent if it was not deemed appropriate. So those are the clarifying points.
Okay. And we probably have no idea how many dependents are in that category. My kids each for 2 years were in that category. Okay, thank you for explaining that. The next question I have is goes back to the dean and the SSM providers. Let's see, Gloria, I think you're in Milwaukee, right? And I don't know what the circumstance is or are you in Dane County?
No, I'm in Madison. Yeah.
You are in Madison. Okay. So, we have a situation where 90% of the providers or more for the Dean plan in Dane County are, as far as I can tell, SSM health related staff. In fact, I can't find anybody who's taking new patients who's not on the website who's not SSM health. And the concern gets back to what happens with won't perform. And I think there's a variety of things that we're all familiar with that affect a lot of people's reproductive health. And the question would be, how does Dean Health not guarantee coverage, but guarantee access in a convenient, timely fashion to these services in Dane County?
Now you're speaking my language. I deal with this every single day. So Dr. Ottenhager and others can also jump in too, but I will say there are many services that are not available in network. So for example, if you have cancer, need some specific cancer care that's not available locally, maybe you need to go to Mayo. If you need a clinical trial, you may need to go with elsewhere. The gender information is a good example. Surgical procedures not available, need to go elsewhere. So all of that's handled pretty standardly across the industry with prior authorization. And this is the same with us. There's a portal, the provider or their staff enter the request, comes into the health plan. If a care is not available in network in a timely manner, so there's both a time and a distance standard. So if it's not within a certain distance or it's not available within a certain time frame, it's approved out of network. So there is a, network of in-network providers, of course, with SSM, preferred providers around there. If the care is unavailable either in SSM or with UW, for example, we approve people to go to Mayo to get their cancer therapy or wherever they need to go to get the care they need. So just because it's not available in network doesn't mean you don't get the care. If it's medically necessary and appropriate, you'll get the care. That's part of what we do is trying
What's
to
the distance? What's
get
the
that to
distance
happen.
and time frame limitations there? You said is this.
Oh, I looked at it this morning. Let me pull up my notes. Mike Weber probably has the notes. So it does depend on your plan type. For commercial, I feel it was it 30 miles, Mike? We talked about this earlier.
He gave it a thumbs up.
Is it 30? Okay,
30 miles.
great.
Yep.
Yeah, and again, I don't have it all memorized, but for commercial plans, it's 30 miles or maybe it's 60 days access, whatever. So I think I missed the question, but I was told it came up earlier that someone was saying that they might have their adolescent need to go to Milwaukee to access care or something when there was a provider closer to Madison. If I'm recalling that question correctly, was that it?
Yeah, so there was a question. Susan, can I call you Susan? That you had last week. That you had last week related to to address.
Exactly.
And then the other thing I wanted to say too is the types of things that Dr. Gloria is addressing is related to planned events. Obviously, urgent and emergent care you can get anywhere. Right across the street. If you feel you need to go to UW and it's urgent or emergent, you're able to go to that. But anyways, yeah. So Susan, if you could explain your situation of between Rogers and then the other provider you had last week.
And
Thank you.
sorry, I missed that.
What we specifically were talking about is not so much just care. We're talking about the need for inpatient care for a child with needing inpatient mental health services. And it's been my impression over the years from the very beginning that SSM does not have access to the Madison-based children's psych and adolescent care facility. And when I asked that question, where they would be inpatiented, the answer was Rogers. And I said, and the location for that is, and the statement was Milwaukee. So those were the answers that were provided to us at that time. We have several very good friends that provide services through Rogers, and they are both cited in Milwaukee.
Okay, I got you. Okay,
my impression, and I tried to validate this, and it's been relatively validated that SSM doesn't have access to the inpatient services at the Children's Adolescent Psych Facility.
So I couldn't speak to SSM specific, but as far as going out of network, that I can speak to, because those requests to go out of network eventually come to a medical director. So if not myself, one of my colleagues see those requests. And I can say that when it gets to the health plan, if someone needs inpatient care that's not available locally, that is available locally at a non-planned facility, we are not forcing them to drive 120 miles to get to Milwaukee to be hospitalized. What I have seen sometimes is an access issue, whereas the facility in Madison doesn't have access, and Milwaukee, maybe they do. And so that's the rationale.
Wait, I'm not understanding that. It's my understanding that there isn't an agreement from the Children's Adolescent Psych Facility to provide services through for instance, the plan that we're currently looking at for our staff at Dean right now, the high deductible.
Yeah, I might need to take that back then because I'm not sure exactly what the SSM inpatient psych capabilities are right now, unless someone else on the call has that info.
Well, again, I know in the past when it was Meritor built the facility, neither St. Mary's, neither SSM nor UW joined that. But when the partnership between Meritor and UW was formed, then that accessibility and pathway opened to those patients, but that pathway has not opened to that facility through SSM. And when I asked that question Monday, the answer was they would be sent to Rogers. And I asked the location, and it said Milwaukee.
Well, I apologize. I wasn't aware of that. I'll need to look in to see where that came from and get you the correct answer then.
How is, if we have an out-of-network referral, how is the billing handled? Is that transparent to the patient, to the covered individual?
I'm not sure I can answer that question. I don't see the billing side of it.
Or do I pay out of pocket and have to get reimbursed, or what?
Oh, I apologize. Let me jump in here. My understanding, and Katie's also on the call on this, if it was a non-planned provider that was approved by Dr. Gloria or her team or her colleagues, then it would be treated as in plan and then paid appropriately. So it would be adjusted, and then there would be visually no difference in the bill that the member would see.
No difference in this. So, okay.
With an approved
it would be treated and paid as in plan.
If with an approved authorization, yes.
But we did mention that you need a referral for an out-of-plan case coverage. Are there restrictions? Does SSM restrict referrals to any of the procedures that it otherwise doesn't provide?
Gloria, I think you probably
Well, I can speak of this from an SSM perspective. Absolutely not. We make sure that our patients certainly get the services that they need. And I think, as you heard from Gloria before as well, I mean, if we don't provide that service within SSM, the appropriate referral is made out of network to get that service done.
Yeah, it's not that SSM allows us to send things out of network. I mean, ultimately, it's our decision.
Absolutely.
So if it's available in network, we certainly try to redirect there. But if it's not, we wouldn't need permission from SSM per se to send someone somewhere else.
Okay, but I mean, for example, I don't know, if there's a procedure that SSM, for whatever reason, doesn't provide, there aren't any restrictions on a physician to an SSM physician to refer that for out-of-network coverage. There are no, SSM doesn't place any restrictions on the physicians to make such referrals.
No, they do not. Emphatically, no.
Yeah, I don't know that that would not be a situation that I've ever seen or heard of.
Great. Hey, Peter, Philip's had his hand up for a while and he hasn't spoken yet.
I'm done. Thank you.
Yeah, thank you, Peter. Go ahead, Philip.
Hey, good evening, everyone. Thank you for all the great questions from the board members so far. It's been nice to just sit back and listen. There's been a lot of good information. I don't have much, but I do have one question. I'm curious about Dean's underwriting process with our population. It's come up a couple times where it's been mentioned that, if we try to stick with a dual provider, it's sort of been applied that the GHC half of our population is a mystery and could bring risk that they're unaware of. And I'm curious, did you make that decision or determination from an underwriting perspective strictly on a claims basis with the population you have access to who currently uses Dean, or did you do any de-identified scoring or underwriting against our entire population?
Al, you want to start, or do you want me to?
So what is and isn't available, what is available from prior, it's generally speaking a 2-year submission of claim data in this case, as well. But the unfortunate part is, the reporting from the GHC part of the equation. It's a quarterly report, and B, it's got a delay of, call it 60 days plus. So in many ways, um, there's a lot of the information is depending on a year and a half, even longer old, that it's based on the GHC population, but that they were provided, and then the Dean part of the equation, they of course have all that. Is that what you were asking as far as what data was based on from?
Yeah, so you didn't do any sort of like an algorithm based or a score based on the de-identified population?
I don't, what do you mean by score-based de-identified? Because GHC they only had 1/4 of claims data that was provided. They don't.
It wouldn't be reliant on GHC. You would be taking the population in a de-identified manner and putting it through a score and algorithm to come up with the risk analysis. I'm assuming you didn't, but I
No,
want to know
so if
if
you're talking about age, gender, and demographics as a whole, that is always part of the underwriting methodology in terms of what's provided to Dean. But if you're talking about specific claim data that each individual has based on conditions and updated status, that wasn't available.
Thank you.
So I'd like to, first of all, good evening, everyone. I'm Katie Beals, and I'm the Director of Account Management. So I work very closely with USI on many of our Dane County school districts and other employers. But your question to underwriting, because that usually finds to my desk as well. We did look at a small amount of data we had with GHC, but we also went back to the data.
Katie, you're breaking up.
Data that you had with, am I? Shoot. Maybe I won't talk to you.
You can try going off video. Sometimes that'll help.
Probably need to take all of you off video. But
Already
is that
better.
better? Is that a little better?
Much
Okay.
better.
Okay, great. So what I was trying to say before was that we looked at GHC, yes, very small amount of information. We also looked at what courts had done and what the claims experience was. So we got that 2-year picture that Al was talking about. We have had employer groups where we have done what you're talking about, Mr. Haven, is where we've actually looked at using demographics in an algorithm, because pharmacy scores are out there, pharmacy data is out there, more in the public domain. We did not do that for your particular group, but we do have some of that ability, and sometimes we do use that in our underwriting process.
Gotcha. Yeah, and so the other thing I wanted to say, and there's been I think a lot of good questions. I think a lot of the wonderings have been mostly answered. What I wanted to say is I think I wanted to reiterate what Peter had said to Kristen Sobocinski, that I think it's awesome to have the creativity behind an idea like this. I think it's what our district needs to be, in terms of how we're thinking about this and how we're looking at a problem like this. I think this is exactly the right kind of discussion and lens. And it's very possible that what's being proposed or something super, super close to it, is where we'll end up. What I'm questioning is more the timing, and is this the right time to do it? And does the district and the board and everyone involved have enough time to make a decision like this, particularly when we start talking about long term and in effect making a commitment to Dean and SSM. And I recognize that Dean and SSM are different, and that Dean covers more than SSM, but effectively within where we live, it really is SSM. It's particularly when you get beyond the clinic and you're talking hospitals and procedures. It's SSM, and so I'm struggling with the timing and the speed at which we're trying to evaluate this and make that longer term commitment. But I do recognize the merits to it, and and the way this could play out long term and the benefits to the district and everyone else.
Oh,
So
and before we
just
get to that, I apologize. I do need to step away. So just wanted to thank you all for the opportunity to come. I know we didn't get to all the questions, but really appreciate it and certainly can answer more questions and follow up. So take care of all and thank you very much for the opportunity.
Thank you.
thank you.
Thank you.
All right. Yeah.
Um,
Elizabeth, I'll yield.
Oh yeah, okay. I want to be mindful of we're coming up on the end of 2 hours here. I know that there's some hands up. Rochelle, Janice, Susan, I see your hand up as well. I wanted to pause though and take a pulse check of the board right now in terms of we are agendized for discussion / action, so we can continue to discuss. We can take action if someone wants to make a motion. We did on Wednesday talk about, sort of having this as a discussion meeting and then, trying to find something later in the week. So kind of before we get back into what we're going to do next, I just want to get a pulse check on everyone for like, how do you want to proceed the rest of this evening and then anytime in kind of a future
How much
meeting
time do we have?
to make a decision?
Mm-hmm.
So Tanya, I'm going to kick that one back to you. I know that there are a couple of kind of competing urgencies here on the district end.
Yeah, so we are trying to bring the balanced budget to the board on October 30th so we can set the levy. And, we had the $1.8 million that we have to figure out how we're going to meet that goal. We can't move forward with finishing that budget until we know where the insurance numbers are landing. So that's one part. The other part is we, and I want to address your comments, Eric, about this being like a done deal. I don't ever want my preparation to be viewed as predetermination. My goal was to really come forward with a robust plan for discussion that people were going to have as many answers to their questions as they could. So that was why there were meetings set up where people could call and ask, if this is my family's situation, if this were to happen, what does that mean for us? Having Dean people available, because we know that open enrollment window is a very short amount of time, and saying to people, well, this change may happen and just wait until it happens, and that just breeds further anxiety. So we wanted people to have the amount of time to one way or the other, whatever you decide, because if you stay where things are at, people that are on Dean are going to be looking at, should we be moving to GHC because of the premium increase? If we move, GHC people are going to be looking at, what does this mean for me? Do I stay on a POS and do out of network, all of those things. So I would say by the end of the week, we need to know which way the board is going. One, so that we can get families the right information and make those, start to make those decisions based on, all parties are going to, obviously always have options to think about what they're looking for, and then also get that budget built, because that needs to go live in the board docs on the following Friday. So,
Eric.
Thank you. Tanya, I appreciate that. And Kristen, just to clarify, it did not certainly mean to accuse anybody. I just feel rushed. And that's my concern, is I feel like I'm rushed. I don't know why I feel rushed, but I do. And I understand that there may be a time constraint. I know, Tanya, I talked to you very, very briefly about this on the 17th of September. That's it. That's all I remember talking to you about it. And it was very brief. It wasn't an in-depth discussion or anything about the HSA thing. It was real brief, as like, would this be something that might be of interest? And I'm like, everything's of interest, of course, if it's cost savings. I just think with, you and Kristen coming from outside of Dane County, there's a lot of things in Dane County that are a lot different here. And it takes a while to understand that and learn that. So certainly, Kristen, my intentions were not to accuse you of anything. It's just when I feel rushed like that, I start to ask questions. And I think I'm even more a little bit on edge of asking questions since our previous administration, I didn't ask enough. So I want to make sure that I'm thorough to the constituents and the people in the community, and asking and not letting anything pass me by that may do that. So there may have been a little emotion on my part in that. And I apologize to you, Kristen, for making you feel like that. That was not my intention. but what I said stands. And I still believe in that. So, but it's important to distinguish that because I do respect the new administration for coming in, and I don't underestimate the challenge that you're faced with. So you should know that I do support you and I do support the administration. But at the same time, if I feel like I'm rushed, there's a reason for it, whatever that is. And that's not a good feeling to have because I think in the previous admin, that's how I felt. And that led to very significant issues. So I'll just leave it at that. And I wanted to thank the good doctor, and I forgot her name for leaving because I did check the specialty pharmacy and there is one. And while they do cover a lot of the other drugs, there are some that they don't. So I would have continuing questions about those specific drugs that they don't cover that probably are not relevant now, but I will get those to the right people and get answers on those. So thank you about that.
Thanks, Eric.
Elizabeth,
Yeah.
if I could just say, I just think from what I'm hearing from the board, and I just think we're too far from anyone feeling any sort of comfort in this decision. And we don't have the time. I mean, let's just move on. It sounds very clear to me that we're just not ready for this. It's a big change. I certainly don't want people to, move forward with something that they're not comfortable with, but we also have to get moving, and we just don't have time to waste. So I just think, call the question, just make a vote on it. Let's just move forward. I don't know that anyone's going to get the answers they need by the end of this week to make any sort of different decision.
That's fair. I appreciate that, Kristen. Other thoughts? Or someone make a motion.
Can I make?
Go
ahead.
Go ahead. Go ahead.
I just want to pop in just really quickly to say we and the administration doesn't want to see folks not well cared for, because the fact that teachers are able to come in and do their jobs and feel supported and have help if they're sick or if their children are sick is the most important part of them being able to do their job and do it well. And not teachers only, the entire staff to be well. It's a pain to have a sub. I know it. I'm a teacher myself. It's a nightmare to have to try to figure out how to schedule appointments when you have a sick kid and how then you can have coverage for your class. So I feel like people are emotional and concerned with change, which I completely identify because it's very personal, your health. But I also think that we may be missing an opportunity to have a new way to think about our healthcare and how we can make decisions that are not only good for us, but also can financially sustain us. So I mean, I guess I feel like that really needs to be stated.
Thank you, Rochelle. I agree.
To Eric's point, we are rushed. That's not good or bad, but it does make it more difficult to make the decision. But this has been for something as momentous as this, it has been relatively little time to make this decision. So yeah, I feel rushed about it too. Elizabeth, your comment, the one that's weighs on me the most is your comment earlier that we're probably going to have to do this next year anyway, so we might as well bite the bullet and move ahead with it.
I mean, I think this is an inevitable path. And so to me, it's like, if this is the path of inevitability, then I would rather go into it known now. It'll help us with budget, and then, we can learn and grow and provide, continuous improvement on it. But also, I mean, we're a total board, right? So this is why we make group decisions on things. This is why we vote. So I think if we're ready, I think it's okay for someone to make a motion and us to do a vote. We'll see where we land.
So I wanted to say to Kristen, I really appreciate you bringing this forward. I appreciate all the information. I feel this is too rushed. I think 3 weeks, and it only has been 3 weeks. I mean, I was gone for 2 of the 3 weeks. Like, I just don't think there are things that I yet understand about how it's going to work. And until we really know how it's going to work for every single person, and it's not about whether people get to stay with their same doctors. I still don't understand like some of the things relating to how it's going to work for new teachers who are coming in, and then they have a high deductible till the end of the year, and then they start a new year and they have another high deductible plan. There's a lot of things that still haven't been answered. So I'm going to make a motion to stay with the status quo.
So the motion would be to vote as it's presented in the agenda, Janice, and then you can vote yes or no on the motion that's in the agenda.
Oh shoot. Okay. Like I don't. What now? Sorry.
No, that's all right. So there was a recommended action in C1, and then you would vote no.
Or amend the motion, correct?
Or
Well,
you can amend it. That's more complicated.
Yeah.
Yeah, Peter.
The right way to do things is to make a motion for the new plan and vote it down if that's what we want to do. That's how we maintain
Exactly.
status quo. You don't need a resolution to follow what we do now doesn't have any meaning actually. So
I'm not even seeing the thing.
It should be in board docs.
In the agenda
Yeah.
and see one. So I just want to add to, I have pretty serious concerns. I think this is a plan that we could move to. And I sincerely appreciate the work and the study and the input from Kristen and Tanya, and from very specifically all of the Dean people and SSM people that have been here to answer our questions. I too feel rushed into a major difference in a plan. The number, the access, the level of care. And if I had a full choice, I'd say we continue this discussion. If the only choice is to vote the plan up or down, I'm struggling with this plan.
We can't meet again later this week. It's just, I think Kristen's question is a good one, right? Like what changes between now and 3 years?
One thing I wanted to bring up is if we do decide to stay status quo, is there still discussion warranted on what that looks like, right? In terms of the structure of that, is there anything to consider with the status quo where the district could still take do a little bit of a haircut on our spend and try to recoup a little bit of costs there in terms of what we're contributing or how we're contributing, or can we balance out the difference between GHC and Dean, or should we? So I'm just wondering if there's two things that I'm thinking about. One is not necessarily, or one thing is the directionality of status quo versus the new idea, but then with the status quo, I'm wondering if there's more to talk about there in terms of how that's implemented.
That would be a change of practice from the district paying 90% of the lowest premium.
Understood.
So,
just wondering if that's something that's worth talking about, given where we're at.
Yeah, and I guess I'd have to check the handbook. I'm not sure if that's contract language or handbook language. So
it's not in the handbook, but it would just add to our costs. So right now, status quo is going to cost $355,000. If we contribute more to Dean, that just adds to our costs.
Sorry, I meant go in the other direction, Kristen. I'm talking about is there anything that we should consider with the status quo to try to meet in the middle from a financial perspective?
You mean like plan design change, like higher deductible?
I don't know. I'm just saying, like instead of it being a binary, it's either we go with the new high deductible HSA and save $170,000 or whatever, or we go status quo and don't save $170,000. Is there any world where we go status quo and it changes a little bit and we save $60,000 or whatever?
Well, it could be, but by the time that we get those quotes back from the carriers, that's how long is that going to take, Al? It just, we don't have time. I don't think we have the time, and it's not going to make a big enough impact to with it.
If I could make a comment about the survey, thank you for doing the survey, and thank Tanya and bringing that forward. There was one thing, just on a care point of view, it seems to be that if you look at that there's more or less dissatisfaction with the Dean Health plan than with the GNC. It seems to be that GHC, not GNC, GHC. It seems to be that there was a moderately larger percentage who rated the GHC plan dissatisfactory than the SSM Health in the survey.
You mean, oh yeah, that's right.
That was my takeaway from it, that there's not a big difference in the satisfaction with the level
I
of
don't know
care
if that's
provided.
true, Peter.
But
Peter, though, if you're looking at the Likert scale, how it's laid out, I don't know if you can necessarily say that. Are you counting the ones in the middle?
Which are neutral.
Middle.
You
can't count the neutral.
I'm
You
counting.
can't count the neutral.
I'm not counting the neutral, Eric. Okay, I'm counting the satisfied versus dissatisfied. That's all.
Okay.
Yeah.
All right. I didn't see it. I didn't see the survey the same way.
It seems to be. I don't have the numbers, but it seems to be when you look at that, that's the impression I get. There certainly aren't very big differences between the two. I was worried that we would have a level of high level of satisfaction or dissatisfaction with one or the other, relative one or the other, and there isn't really that significant difference in the data.
Yeah,
and I think that that's an important point.
The majority of people for both said that they would stick with the same plan.
Right. Yep.
And I would just interject there that I question if people really understand what that's going to mean for their paycheck, and if that's going to push people towards, make some changes. So when people talk about like, we want more time and do we do this in a year, I think it's going to be a bigger disruption, because I think this plan will cause some people to move to GHC. And then if we need to move to a design like this next year, because our budget's not going to get any better, then we're going to disrupt people again. And so I absolutely appreciate the conversation that it feels rushed. I just think we have to, as we move forward, this is going to have to be an expense we're just going to have to expect, and maybe have to think differently about how much the employee pays as we move forward. Which totally appreciate that it's a tight turnaround time, but I feel like we're inadvertently, if you think it's just kicking the can down the road, like that's my fear.
Yeah, I appreciate that. Rochelle.
I agree with everybody saying how fast we're moving, but I think we're just kind of in the space where there's not a lot of time. Nobody's trying to pull the wool over anyone's eyes. So I'm going to make a move to approve the adjusted employee health insurance plan design effective January 1st, 2025 as presented.
Ooh, girl. So if you want to maintain the status quo, you would vote no.
Can I get a second?
I will second that.
Thank you. Further discussion. Eric, I see your hand.
Yeah, I think that maybe I'm wondering if Tanya, you're overlooking that people would pay more to keep the plan that they're on. That's my question. I think we may be overlooking that fact that people on GHC may be willing to pay the 5% more to stay on the plan. Now, the dean is different, right? That's a more significant increase. But from the feedback I've got, and even on the survey, I could justify that people with GHC are willing to pay more to keep the plan they're on. So yes, I understand what you're saying, but it seems like we're overlooking that fact, right? So we're talking about cost savings, and we're also talking about an increase to the employees that have a certain plan. Would they pay more? And from what I'm gathering from both the survey response and the feedback I've got directly from people is that yes, they would be willing to pay more. So I'm wondering what you have.
Yeah, I think people absolutely said, yes, we would be willing to pay more to stay. I'm hopeful that people looked at, that is going from, $180 some a month to I don't know, what is it, 312. So that dean part is high. On the flip side, if we were to move in a high deductible plan and people are saying they were willing to pay more to stay with GHC, that's an option. People can totally do that. I just want people to have a real understanding of when they say that they would pay more, what do they mean? Because on the flip side, the question of, are you interested in paying less premiums? The majority of people said yes. So I saw those a little bit as a juxtaposition. And I want to make sure that people understand how much they're talking about when they say pay more. So.
Thank you. And again, telling you from my feedback, they would be willing to pay more. That's what I'm getting from my information. So.
Mm-hmm.
Janice.
And I think the difference between whether we end up eventually moving even next year to something that's different than the status quo is that people will have more than 3 weeks to like think about it, plan, like figure out what they want to do, get all their questions answered. And I think how we do things matters. And I think having a chance for people to like all be brought along in the plan, or even be able to like suggest ideas. Maybe there's things that like we haven't thought of that can be suggested by employees. So, you know, I think all of those things are important. And I think giving it a year, in my perspective, is the best way to go.
Yeah, I just note from the survey
Hello.
that 30% of the people on the Dean plan would move away if we kept the status quo.
Yeah.
Would move away from it because of the higher costs.
Huh?
Oh, can someone, whoever's not muted, can you mute yourself, please? Thank you. Mike, did you have something you wanted to add? I see your hand up over there.
No, I just want to be, first of all, I appreciate the discussion. We appreciate the opportunity. As you know, we did bring some extra people here today because we really felt, as we committed to last week, that we want to give you all the information you can possibly have and then make an informed decision. So whatever decision you make, we very much respect it. We appreciate it. We will continue to be partners with you and take care of the staff that we currently are lucky to take care of. But I also want to be respectful of this discussion. Do you want us to leave and let you continue this discussion? We find it very interesting. And I mean, it's great dialogue. And I appreciate this is really a hard decision, whatever you make. So I respect that. And I hopefully you got that message from us last week. And this is just the continuation of it. But I really want to be respectful of your process at this time as well. So that's the reason I
appreciate that. You're welcome to stay and watch democracy in action here. But also I appreciate the fact that it's 10 to 9 and you might have some friends that have other things to do and may want to bounce off. So you all can totally decide for yourself.
My mom used to be the president of the school board in Door County, and sometimes she'd get home after 1 or 2 o'clock. So I've got at least another 4 hours to watch it.
That is why you're excited about these things, Mike. I'm like, there's a small handful of us who get excited about school board stuff. So welcome to the club. Any other discussion? Yeah.
I got to getting back to the survey. There is this thing. There's these questions. How likely are you to, if stay on the plan or adopt? What is it? Sorry, like on the last page is a question for people who aren't currently insured. Should the district adopt the proposed high deductible plan? How likely are you to enroll in the district health insurance? There are 3 answers, 1, 2, and 3, but there's no explanation about what 1, 2, and 3
it's
are.
the same. It's the
This is an
likely.
error.
Is one likely or one not likely though?
Let me pull it up exactly. 1 is not likely and 3 is likely.
Okay, thank you. That makes a huge.
Is
on the
that
last
for the
question,
other
that
ones
makes a
too,
huge
like
difference.
that,
Thank you.
Tanya, as well?
Yes.
1 is likely and 3 is not likely.
Yes.
Wait. No, 1 is not likely. 2 is neutral. 3 is likely, correct?
Okay.
Yeah. Yeah, likely to not likely to likely. Yes.
Yeah. So like, for example, should the district adopt the proposed plan? Are you going to stay on the health insurance? And under the Dean question, 62% of respondents said they are likely to stay. And with GHC, we had more of like a kind of like an even, almost like a third almost, right? Of likely to stay, likely to leave, and folks that are in the middle that are like, I don't know, I got to wait and see probably what's going on.
And I think we asked that question for a reason. There are people that do have options because of their household situation. I'm not one of them. But some people can choose between, one partners or the other. And then there's that cash incentive for them to be able to do that. So we were trying to gauge a little bit about, would people be taking us up on that option that would be available in the new proposed plan.
And can I just make a quick comment, Elizabeth, that I am one of those people that, let me be really clear, the Dean plan would 100% benefit my family at this time. There is no doubt about that, okay? So I want to be real clear about that. So I'm doing my best to represent the employees in the district and the constituents that I've talked to and take myself out of that equation. But the Dean HSA plan would 100% benefit my family. There's no doubt about that. In many, many ways, whether we took it or not, it would benefit my family. But it's not about me. It's about the employees that I've talked to in this district and the taxpayers I've talked to in this district and the impact that it's going to have on our teachers and our staff. So I want to make that real clear, that my bias is actually a little bit switched on this than what it would normally be.
I appreciate that, Eric. I will say, I think like I said earlier, I think that it is a good plan design. I think that it'll benefit most folks, not everybody, and it's always hard to switch. But I think it'll benefit most folks and it helps us do right by district budget, which I think, like I said at the beginning, I think is our number one responsibility this year. I think that's or in the years to come too. I think that's what the community is expecting us to do, is to look at different creative solutions to try to solve for problems. I'm appreciative that the HSA contribution increased from the last time. I think that helps sort of sway myself quite a bit on that one. But to Rochelle's point, I think there's an opportunity here to start making some really important critical moves on budget. And my opinion is that we'd be remiss if we didn't take it.
I'm still seriously concerned about asking over 200 people to change their healthcare provider, some of which just started teaching in the school district.
Yeah, I appreciate that. I mean, I appreciate that. It's not a thing that I would enjoy asking people to do. All right. Any other discussion? Yes, Eric.
I would just say to the other board members, I wouldn't underestimate the decision that every board member is going to make. And I certainly respect every board member's decision. That this issue is probably the most significant issue that we will vote on, much more than other issues that we have in the district. And I just want to stress that I'm sure we've all had conversations with people and we've had emails from people, but I certainly don't take this lightly. And again, I don't want my emotion to be misconstrued as an accusation. It's not that. I do appreciate the administration. I appreciate this process and I respect the process. But this is a very heavy decision, and I've struggled with this for the last week since we've known about it, because I know it's directly affecting the one thing that is most important to all of us, and that's our health. Because if we don't have our health, we don't have anything else. And it is a vital, incredibly important thing that rises above everything else: wages, jobs, everything. And we've all have our own stories about that. So I can't, at this point, I just can't feel confident voting about this. So when we vote, I just can't feel, I don't feel like at this time, I like what Janice said, that, the rush feeling about this, maybe we look at this for the next year and have some time to really, ask these questions, to talk about this, to develop a plan and inform our employees so they know. I would feel much more comfortable about that than making this decision now, knowing that this is likely the way, as much as I don't like this, future of health insurance, likely the way that things are headed. I don't like it. I don't think it's good. And I think there are a lot of holes in it. Maybe those will be filled as we continue on, because this is new. But right now, it feels a little too rushed for me to make this decision.
I appreciate that, Eric. All right, we'll do a roll call vote if there's no other question or comment. Great. I'm gonna go my left side of my screen and make my way over. So Eric, you happen to be first.
No.
Janice.
No.
Rochelle. You're on mute.
Yes.
Philip.
Nay.
Susan.
No.
Elizabeth, yes. No's have it, so the motion fails.
You
So
didn't
that means-
ask me.
Oh, I'm sorry, Peter. Peter, you're underneath Mendy. You weren't in my squares anymore. Sorry, Peter.
Oh, now I can avoid voting, but no, I would vote yes.
Yeah, so it's still 3-4. So
Yeah.
motion fails. So we will have our status quo insurance for the year. Good discussion, everybody. This was a good, important decision to make. I want to reiterate what Eric said. Like, I think it's important that everyone vote the way that they feel good and comfortable, so that we can start moving forward on all of these really important elements for a district. So thanks for 2 full meetings of very robust discussion. I really appreciate it. And I think we will see each other again on the 30th. Is that the next board meeting we've got?
Yeah, on the 30th is when we bring the budget, which most likely will not be balanced, and the levy, set the levy.
Yeah, sounds good. All right, if there anything else, thank you, Mike. Anything else for the good of the group today? Otherwise, I would love a motion to adjourn.
I move we adjourn.
I'll second that.
Great. Roll call vote. All those in favor?
Aye.
Aye.
Okay. All those opposed? Ayes have it. Motion carries. Meeting is adjourned at 8:57 p.m. Thank you, everybody.
Thank you.
Thank
you.
you.